With the permissions of the organizers, uh, we begin the third day. So, on behalf of the entire team of ICanCaRe, IHBAS and Gujarat University, I welcome each and every one of you to the third day of the International E-Conclave on Tobacco Cessation. Welcome our Chief Patron, Rotarian Kalyan Banerjee, our Patron, Professor MC Mishra, Chairperson, Professor Dr. Nimesh Desai, and our Co-Chairperson, Dr. Rakesh from Gujarat University. I also like to welcome the entire organizing committee who have made this particular event, which a month-long event, divided into four sessions to be a fruitful event for effective implementation of tobacco cessation. I would also like to thank our supporters with whose help we could materialize this and make it a reality, make this event a reality. I would like to thank ISO, FHNO, Indian Chess Society, Delhi Psychiatry Society, CMHARTS, RAGAP, RSD Hospital, and IDS and Santosh University. I would also extend my gratitude to our pharma partners. We move ahead with the scientific session, so I hand over the dais to our Master of Ceremony, Dr. Nandita Divekar. Dr. Nandita Divekar is a consultant in anesthesia and critical care at Medway NHS Trust in UK, and she is the leader there for smoking cessation in her hospital. And she is very passionate about tobacco cessation, mostly smoking cessation, and has been pivotal in starting the stop before the OP clinics. And she has also been awarded for the CO award for the brilliance to study the Ottawa model. So I welcome Dr. Nandita Divekar to take this scientific session forward.
Namaste and thank you very much. Good morning, good afternoon, and it's good morning. It's a very beautiful morning here in the UK. And thank you very much, Dr. Pavan Gupta, Dr. Reena, and Dr. Nimesh, sir, for allowing me to moderate this session. Yeah, the next session is the interesting panel discussion. My duty here is to introduce Dr. Ashish Deshpande, who is a moderator. No, that's the wrong one. Can we go on to Dr. Ashish Deshpande's one before? Yes, Dr. Ashish Deshpande has done his graduation and post-graduation from, say, GSMC in KM Hospital from Maji, Mumbai. He's a program director, Samarpan, Psychological Wellbeing and Rehabilitation Services in Mumbai. And he is also the director of the Center of Mental Health Advocacy Research and Treatment Services. He has a lot of ongoing research projects, and he's an ideator and advisor of De-Addiction Connect, Community Place Rotary Facilitated Addiction Prevention Initiative, and also for the Indira Gandhi Institute of Developmental Research Campus Assistance Program, ICAP. Over to you, Dr. Deshpande, for the wonderful panel discussion.
Yeah, thank you, Nandita, and thank you, ICanCaRe Foundation. I think it's wonderful to meet people from all across the globe, and thanks, Dr. Pavan, that we are meeting here and trying to discuss an important topic of tobacco, because we all know that it causes a lot of morbidity and mortality. And still, it's the opinion that people usually have about tobacco is very permissive. And it's something that is never criticized, never objected. And that's for generations together. A particular role model is carried through, and the young kids get vulnerable at vulnerable ages, take to these products. Well, today we have a panel discussion and we are a little short of time. So I would like to cut short the questions, but before that, let's go to our chairpersons, and we have Dr. Sandeep Kadam, who is a practicing pediatrician since more than 30 years, and he is a visiting consultant at one of the eminent, prestigious Jupiter Hospital in Thane, and he is immediate past District Governor, Rotary International. Welcome, Dr. Sandeep Kadam. And we also have my colleague, my friend from KM Hospital, Dr. Harshad Thakur. He did his MBBS with me and MD in Preventive and Social Medicine from KM Hospital. And currently he holds the director's post at National Institute of Health and Family Welfare. He has been extremely helpful in getting me the NIHFW clear approval for the research program that we are doing on preventive aspect of substance use. He is also a professor at School of Health System Studies at Tata Institute of Social Sciences in Mumbai. And he worked at the Department of Preventive Social Medicine in our college for a pretty long time, from 1993 to 2000. So welcome, Harshad, on the conclave, and we have a lot of eminent doctors here. We know that the morbidity and mortality of tobacco goes into all various systems of human body, and cardiovascular system, respiratory system, and cancers being the predominant ones. We have pulmonologists, cardiovascular system experts, and oncosurgeons on the panel. Along with them, we know that as Dr. Jirge said, that there are lots of complications that happen in the oral mucosa. So we have somebody who is a expert in that field from Sydney. And we have one more information technology expert right from ICanCaRe Foundation. Please go to the previous slide. So Dr. Lancelot Pinto, I've known him for a long time. We share the same city, and he has been at Hinduja Hospital, has been a pulmonologist of repute. But what probably distinguishes him differently is of course he's got a gold medal in DNV and he has trained in McGill University. But I believe that he has been conducting nicotine clinic for donkey's years in Mumbai. And as a young pulmonologist, as he joined, and he initiated something that usually pulmonologists in those years would not initiate. And that is something that probably distinguishes him from the rest. And of course, he has a busy practice in pulmonology, and he treats all kinds of complicated cases that he gets. So that's Dr. Lancelot Pinto. Let's go to the next. Dr. Jayesh Patel, I have been introduced to him as Dr. Pawan Gupta's teacher, mentor, philosopher, guide, and friend. So he has been introduced before also. So welcome, sir, on the panel at the last moment because the other oncosurgeon was not available. So thank you very much for being there, Dr. Jayesh. The next slide, please. And we have Deepak Raheja. He comes from my biradari. He's a psychiatrist and he's from Delhi. He is the vice president of Indian Association of Private Psychiatry. He's on the National Executive Council of Indian Association of Private Psychiatry. Hope Care is one of the brainchild of his, where holistic psychiatric treatment is offered. There are inpatient facilities, outpatient facilities, group therapies. I know he does a lot of work in de-addiction. He started a Wellness Hope, the educative arm of Hope Care, and he has been awarded the Indira Gandhi Priyadarshini Award by Government of India. So congratulations for the award and welcome to our program, Dr. Deepak. Then we have right from down under Dr. Garima Sharma, who is an endodontist and practicing in Sydney. She is involved in teaching of dental students at University of Sydney, and she's the vice president of Australian Society of Endodontology, the New South Wales branch, and recently felicitated by Hindu Council of Australia for contributions to science. And we have Dr. Rakesh Kumar Chawla. He is a pulmonologist and a senior consultant of respiratory medicine, critical care, sleep disorders, and interventional pulmonologist. He's a chairman of Department of Respiratory Medicine and Care and Sleep at Saroj Super Hospital in Delhi, and working as a senior consultant in respiratory medicine in Delhi. He's a consultant, Department of Respiratory Medicine, and senior consultant, Ministry of Health Kingdom of Saudi Arabia. Dr. Chawla is one of the topmost international pulmonologists with more than 30 years of experience. And he is a pioneer and has done maximum cases of endobronchial placement of glue in cases of hemoptysis in India. And he is a member of Governing Council Chess Society and is elected zonal chairman of Indian Chess Society. And we have Dr. Dilip Kumar. He's a cardiovascular system fit as a fiddle. He's an interventional cardiologist and electrophysiologist and a chief academic coordinator, Medical Institute of Cardiac Sciences. Professional experience of more than 20 years under his belt. He is well versed with pacemaker implantations and all the electrophysiological procedures that a cardiologist usually is. And Dilip Kumar has been awarded as the most innovative cardiologist in West Bengal, as the healthcare pioneer of East, awarded by the Times Group. Next. And along with that, we have a technologist, where else from but IIT, who has been, I think, a backbone of ICanCaRe Foundation. He did his BTech and MTech from IIT Kharagpur. He worked with Samsung, and then most likely he left his lucrative job in Samsung to go for something that was very dear to him, some kind of community work. And that's how he came to ICanCaRe Foundation. And he is, I think, the brain behind all the apps that ICanCaRe Foundation has developed, all the social media presence that ICanCaRe Foundation can garner. So thank you very much for all of you being there with me. We would, for the want of time, we would probably have to curtail the questions a bit. So pardon me. Well, I would like to go with Dr. Deepak to ask you, sir, why do people consume tobacco in the first place? Any ideas? People know for years that they have tobacco has lots of complications. Why still do they go ahead and consume tobacco?
Sir, good evening. Am I audible?
Yes.
Thank you very much for having me here this evening, and thank you very much, Dr. Deshpande, even for the paucity of time you took, very meticulous details in introducing all of us. Thank you very much, Dr. Sai sir and Dr. Pavan Gupta for having us here this evening. Coming back to your question, because I know we are pressed for time today, why do people get addicted? I mean, after this very elaborate session that we've had this evening, with speakers doing more than justice to the topics assigned to them, I feel there is little left to be said. But at the cost, at the expense of paraphrasing what has already been said, I think tobacco is perhaps one of the most addictive substance available on earth to mankind. And I do really think it is perhaps more addictive than crack cocaine. A lot of literature says that. More people die because of tobacco-related complications than they die for many substances put together. Yet we are dealing with a substance that's legal, that's available in the vicinity, next door, and we tend to, like Dr. Vishal said, Dr. Pooja said, and then the speakers thereon said, it is a substance that has very intense psychological underpinnings. It has very intense behavioral underpinnings. It has very intense biological underpinnings. So putting that all together, we deal with a substance that instantly crosses the blood-brain barrier. It goes and binds with certain receptors, begins to produce a trickle of the reinforcing pleasure neurochemical called dopamine. You know, the same neurochemical that gets us addicted to the social media, that gets us addicted to all pleasurable stimuli. And here we have a substance that perhaps repetitively goes on to start firing the neurons with the help of dopamine, thus leaving the brain vulnerable to want more. Ye dil mange more. The high comes, and then the crash comes, and then the high comes, and then the crash comes, and we get addicted to the butt because it becomes cool. I think alcohol and tobacco, both legal substances, they are lobbied surreptitiously, so cleverly by governments across the world because it is a big revenue churner. It is a big tax churner for governments, for politics, even though the tobacco farming is one of the biggest feeder to the farmers, but it also operates in a lot of ways with cartels that make huge amount of profits, and for them to surreptitiously slip up a part of those profits into perhaps very covert advertising, where in a movie, on a television screen, in the environment, you start picking up cues which perhaps reinforce that smoking is cool. It takes away stress. You have a feel good factor. And then 7 on 10, some studies even say 9 on 10 smokers, they desperately want to quit. They perhaps keep making plan that they are going to quit, but they never quit because they're also interwoven, embedded with the thought. Like again, for the fourth time, repeating what my preceding speakers have already said. Mark Twain, quitting to smoke is the easiest thing in the world to do. I have done it thousands of times. So I plan to give it up, but I know I will not be able to give it up because that becomes a way of life. It becomes a way of life for me to think creatively, to write creatively, to talk to my patients creatively. If I'm a surgeon, to operate creatively, to bust stress as soon as I come out. So
Yeah.
I think Dr. Deshpande, maybe
Right.
kind
Yeah.
of gives us an answer to why people get habituated and they get addicted to tobacco.
Right.
Nicotine.
So at a vulnerable age, when people actually make a choice of taking the first smoke, at that time, a lot of information on why they should take up the butt is available, but why they shouldn't is unfortunately not available, and that's the reason probably the hedonic calculus makes them take a decision that maybe I can try it out. Once the person starts smoking, the first people that probably come to know is, of course, the parents, and the parents don't give it too much importance or whatever. But of the health professionals, there are family physicians, there are dentists, and there are pulmonologists. These are the three people who probably see the patient to begin with. So I would like to ask Dr. Garima that I'm sure that when you go to the close quarters of an oral cavity, the whiff of cigarettes must be the first alerting factor that must be letting the endodontologist to know that, okay, this guy is a smoker or this person is a smoker. And maybe as Dr. Jirge said that in her presentation, or Dr. Patwardhan said in her presentation, that they're not even willing to consider that there is a problem. So in such situations, what do you do? How do you initiate a communication or a conversation about tobacco cessation?
Hello, good evening, everybody. Am I audible?
Yes, you are.
Okay. Thank you, Dr. Deshpande, and thank you, Dr. Pawan Gupta, sir, for giving me this opportunity. It's good to be connecting across the globe to everybody, and it's a great initiative by ICanCaRe, and I think Dr. Pawan Gupta, sir, is doing great. That's actually a very good question. I think we as a dentist see the oral effects of smoking, as we have seen by Dr. Jirge's presentation, that there is a lot of impacts of smoking, right from cosmetic effects like staining of the teeth to more harmful cancerous lesions. It has an impact on the periodontal disease. So whenever these patients come to us, we can see that they are more at a risk of periodontal disease, at least 3 to 6 times more than any non-smokers. We see receding gums. We can see, more tooth mobility, red and white patches. So whenever we do an oral examination, I think if you see something which is a little bit unusual than, the rest of the patients, then it's very important as a dental clinician that you ask the history. Is there, it's very important you ask them, do they smoke? If they do, then you need to assess, what is their nicotine dependence. Of course, many people are not receptible to being told that they need to quit smoking. Some of them are, some of them are not. So if they are not receptive to listening or to be told that they need to quit smoking, then it's very important, and we have a behavioral therapy or a motivational therapy in order to point them to the right direction. And in Australia there are a lot of, like ICanCaRe, there is ICanQuit, which is pretty similar name as well here, which is a government funded schemes that actually motivate people and put them into the right path towards smoking cessation. And also, whenever we do that, whenever we advise them, and if they are motivated to quit smoking, we need to also tell them that what are the impacts, what are the implications. It's just not a impact on the health, but also the oral health. It does have an impact on their, overall well-being of the patient. So it's important that we motivate them, we encourage them, we put them in the right path of smoking cessation. We arrange follow-ups to see if they have started on their journey or not. And it's very important, especially here, everybody is very keen on their oral health. So we do have actually 6 monthly checkups here, which also helps us to do regular oral health screening. So we make sure that if there are any changes in the oral cavity, it's being picked up pretty early.
Yeah. Let me go to Dr. Lancelot here. Hi, Lancelot. Good to have you here. And the question to you is, Dr. Garima said that, before even any pathology appears, there are some things that you need to communicate. As a doctor, you just have to tell them that you are smoking, it's not good for health, blah, 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 blah. And would you like to do something about it? Whether it's an oral problem or maybe some kind of a smoker's OPD, how do you get along with those patients with having a conversation about tobacco cessation in your clinic?
Thank you, sir. Thank you for that generous introduction earlier, and thank you for inviting me to this. I think I'm in a fortunate position by virtue of being in a respiratory clinic where somebody who's coming with a respiratory problem is far easier to convince than somebody out there in the community who perceives oneself as being absolutely healthy while continuing to smoke and therefore wonders what is the need to give up smoking. However, that being said, I think nudges always help. I think there are studies which have shown that just a brief counseling of about 5 to 10 minutes by a physician, just kind of sensitizing the patient about the fact that he or she is smoking, can actually improve quit rates by about 2 to 3%. And, that sounds like a small number, but on a population scale, it's definitely big and it's multiplicative. So every time the person comes, if the person goes to multiple doctors, has different points of contact, even with the general practitioner, if it's said over and over again, I think that serves as a nudge. It also helps to think about the different non-health related nudges that you can give. For example, it's a known fact that children of individuals who smoke tend to have more middle ear infections, tend to have upper respiratory tract infections more frequently than children of those who don't smoke. And I think children are a point where it's a nudge. When you speak to a person about their children, it's easier to convince them about behavior change than when you speak about their own health. In addition to this, of course, at a community level, smoking helplines, which are there, advertisements of any kind will always help. The reassuring statistic, though, if you look at the Global Adult Tobacco Survey, the reassuring statistic is that more than 90% people in India, even in rural India, believe that smoking is bad for their health or consumption of tobacco is bad for their health. So I think the knowledge is in place. Close to 50% of them tried to give it up in the previous year. So the motivation, at least in a half of them, is already in place. And I think this, what we perceive as a lack of motivation is very often a lack of confidence, which has already been mentioned before as well. People have tried to give it up in the past, people have failed, and therefore to cover up those failures, they adopt a stance where they say, we are not really interested in giving up. So I think assisting such individuals goes a very long way.
Yeah. Thank you. Apart from the association of tobacco with oral cavity and the respiratory system is probably very well understood. I would like to ask Dr. Dilip Kumar with us. He's a cardiologist, and I would like to ask him, is he there on the panel? I can't see him on the panel.
Time.
Sorry?
Dr. Dilip has not joined, sir.
Oh, okay. So I can yes, Dr. Chawla, you can take his question that its affection, the tobacco's affection with the respiratory system is understood, very well understood. But what is the association with the cardiovascular system or the rest of the body? How does tobacco cause a problem in other systems? Sir, you have to unmute yourself.
Right.
Yeah.
Being a pulmonologist, it is fortunate that when patient comes, it's a routine part in asking the patient when he sits with you, do you smoke? Do you drink? The first question when he says, because he has a cough. So you want to start when your history is taken, it's a part mandatory to ask, do you smoke? And still those who are smokers still have a feel of guilt. Those who are young, they try to conceal it from their parents, and those who are old and are coming with the disease, now they are regretting, they know they have to leave it, there is no option. And you don't have to do anything. I in the beginning, I must thank for the introduction, Dr. Deshpande. Thank you, Dr. Pawan Gupta, for inviting on behalf of Indian Chess Society. I think it's a wonderful activity of tobacco cessation by ICanCaRe Foundation. So to continue with this, when the patient develops a disease, especially of the lung or of the heart, if he has a coronary artery disease, which is directly related with smoking, atherosclerosis of the vessels directly related with smoking, there is no part of the body where vessels are there and smoking does not affect. But primarily, majorly, it will lead to COPD, it will lead to precipitation of asthma attacks, it will lead to chronic bronchitis, it will lead to emphysema, coronary artery disease, heart attacks, CVAs, brain attacks, you can say, peripheral artery thrombosis, what you call is as a DVT, the vascular thrombosis of the peripheries. Then patient can have more important is the lung cancer apart from the oral cancer. The moment he gets a talk and suspicion of some opacity in the lung, now he begs for his life. Forget about tobacco. Forget about anything. You don't have to do anything to ask him to stop smoking. He begs for the life, Doctor Sahab, ab to chhod diya, ab to theek kar do. When he comes with excessive cough, smoke, the COPD, breathlessness, he says, Doctor Sahab, 1 महीना पहले छोड़ दी, ईब तो ठीक कर दो. Arey, this guna which has been done, you have to be very, very clear to him. I was listening to them, single smoke, single cigarette creates so much of damage, and you are smoking for last years. So we tell very clearly to the patient, if you murder once, the saza is the phansi. You smoke once or for the life, you cannot be repeatedly hanged. You have to stop it. वो तो छोड़ दी डॉक्टर साहब, अब ठीक कर दो बस. You understand? So you don't have to. But this activity of smoking cessation is a wonderful initiative, and you help the patient to stop smoking. He gives an history. We tell them very clearly the burning edge of the cigarette is at 924 degrees centigrade. The butt which he is holding is around 28 degrees Fahrenheit. 7.5 minutes the average cigarette will finish. So his life of 7.5 minutes is gone. So you tell him very clearly, keep smoking, and you are putting your life in smoke for 7.5 minutes with every cigarette. 7,000 plus chemicals are burning at a degree of 920 degree Fahrenheit. Imagine how much damage it will do to the lungs. It's a chronic damage. I tell them, if you start putting your finger on a stone every day at the same point, after 20 years, you will get a spot on that stone. Similarly, the cigarette damages your lungs. Don't expect in one day you are going to have lung cancer. You will have it, don't worry. It is well established by science. The single most important cause for lung diseases is a cigarette smoke. So, and if they are starting cigarette, it will lead to goblet cell hyperplasia, excessive amount of mucus, smokers cough. You have to tell him if it's an excessive mucus, again, they are the nidus for infections. So these are the changes which happen to the lung, to the body system. There is no system of body which cannot be affected by.
Right. Yeah.
Thank you.
Yeah. So we have covered the cardiovascular, the respiratory system, and then we go to cancer, where Sir mentioned briefly cancers and something that human species is absolutely scared of. And the teratogenic effect of tobacco is known, and tobacco products are being criticized. Sir, I would like to ask Dr. Jayesh Patel, sir, that he is an oncosurgeon, and when a person with cancer, which you feel has been probably precipitated because of the chronic smoking that the person has been doing, what exactly do you tell him? Do you have to tell him anything, or he's willing to quit, or does instilling more fear, does it help? What is your experience? Sir, please unmute yourself, sir. Yeah, thank you. Yeah.
So when somebody is diagnosed of cancer and they come to our clinic, now I don't think it is good to talk about what he has done in his life. Done is done. Yeah. So as a treating doctor, I would address that you should stop smoking. But by that time, he's convinced, whatever he has done, and he is suffering for the same cause. So what we like to do is we try to concentrate more on our clinical treatment of the patient, but at the same time, we highlight that, if you have not done this, probably you would have been little safe. That is a time we should not be talking about de-addiction, stopping tobacco. So firstly, we do our job of treating the cancer, and then as soon as we finish our job and they recovered, at the same time, we will involve our psychiatric colleague. He would be coming in the picture, and thus parallelly, he would try to de-addict the patient. Now, as we are aware that in India, it is 40% of the load of cancer is mainly because of tobacco and alcohol. If you are in Western India, like if you are in Maharashtra, Gujarat, or Rajasthan, it is almost 52 to 55% of the cancer. They are predominantly because of the tobacco, and people are aware, But it is compelling nicotine which would push them to consume. I think as a group of doctors, including all subspecialty and specialty, as I told before, that we should be convinced that we have to spare 5% of our time for preventive medicine. But for me,
sir, related to this, I would like to ask a small question. Many a times, yes, people question our wisdom of giving nicotine replacement therapy. Okay, and they say that it's from the frying pan to the fire. You are giving nicotine. Why is it called therapy? Why should it be called treatment pertaining to cancerogenicity? So, what is your answer?
Sir. The question is like somebody is addicted to some medicine, like a surgeon is addicted to do surgery. When I suffered COVID, I was off the job for 15 days. But, from internally, I was so compelled to start my surgical practice. So it is like nicotine is so addictive that, guys, when you say that on one hand, you are refusing nicotine, on the other hand, then I have to explaining about withdrawal symptoms, not only psychological, but social as well as physiological. Say in Rajasthan, they allow afim to be consumed on a license base. I have operated many patients, but believe me, my psychiatrist friend would not allow them to get withdrawal of that. So they would continue less dose of afim for particular days and duration, and then gradually they'll be weaning off. So, that takes little time to explain the patient. And I know in today's India, I know we all doctors are so busy because volume of the patient is huge, number of doctors are less, but still, I think I would request everybody of us to spend a little more time to these poor guys who are sufferer of addiction.
Yeah, yeah, really, really. If all of us do those two movements for the patient, okay,
Yes,
that
sir.
would make a lot of difference. So
And believe me, we are
yeah.
role model, sir. The people
Right.
now, they believe that yes, doctors are professional, but still, few of them, they believe that we are God. So let us act as a
Yes.
God.
Yes, yes, yes. So I think from strokes to cancers to oral mucosa problems, you have covered a lot. And as sir said that loha garam hota hai tabhi usko bol do, okay?
Yes.
Immediately after the therapy, cancer therapy or stroke or whatever serious disease that he has had. I would like to again ask Dr. Deepak Raheja. Well, we all know as de-addiction experts, well, people who practice de-addiction, that
Yes.
stopping is easy, but staying stopped is difficult. Okay, so why is it so difficult to stay stopped when it comes to nicotine? Because you said that it is one of the highest difficult to quit substances in the world. So why is it so difficult to quit nicotine when it compares to synthetic drugs or alcohol? Any idea? Hello?
Unmute.
Yeah,
Yes.
yeah.
Am I audible?
Yes, yes.
Sir, so like we've been saying, nicotine is a lot more addictive and difficult to leave than many other drugs. A, because it is easily available. B, it can be consumed in a fairly unassuming setting. C, it crosses the blood-brain barrier very, very rapidly, virtually in about 7 to 8 seconds after the first inhale, first puff. It crosses the blood-brain barrier, begins to create a surge of dopamine, and then subsequently also a minuscule surge of adrenaline, which gives you the feel-good factor. And because it is, I mean, we've spoken a lot about the behavioral aspect, the habituating aspects of nicotine dependence. It starts getting woven as a way of life. I mean, you can just step out, have a cigarette pack in your pocket, or just go to the next door shop or the panwala, pick up a cigarette and start smoking. So I mean, it's as akin to, if I was to draw the commonest analogy, the thing that would come to my mind is the cup of coffee or the cup of tea, which is so readily available. It's within our household, and so we tend to keep consuming it. And like Dr. Rakesh Chawla and my other predecessor was saying, along with, let's say, 7,500 or even more addictive chemicals that go in, at least 40 have been identified to be carcinogenic. And here we have the culprit called nicotine, which is very, very addictive, extremely habit forming, and gets woven becomes a friend who you find yourself inseparable from. And asking to leave your beloved, asking to divorce your beloved with whom you've spent 5 years, 10 years, 20 years is really difficult. And research has also, statistics have also shown that people who stay put are people who started early, don't have enough reason. And like somebody said, maybe just the right counsel. I mean, the reasons have to come from within. The reasons have to come from the person who's wanting to quit. And which is why I think the most successful therapy in smoking cessation is motivational enhancement therapy, because it's non-confrontational, it is respectful, it evokes respect from the person, and helps to it helps to meander the path of his thinking to find the reasons from the subject, from the person himself, as to why he wants to quit. So I think it's very important for us to keep in mind that we should not be judgmental. I was reading, somebody said, even WHO says that it takes a few non-successful attempts before the person quits. So with each non-successful attempt, there should not be an attitude of judgment. There should still be unconditional respect and empathy towards the client, and helping him to resurrect
and solidify the mechanisms as to why he wants to quit and keep up being on the wagon and the recovery process.
Right. It is said that it takes 7 falls to make a rider, and it applies to even nicotine quitting also.
Yes.
And as you rightly said, that there are multiple drugs who cross the blood-brain barrier very fast, and they cause havoc in the brain along with nicotine. But what singular factor that probably differentiate nicotine from the rest of the synthetic drugs or all the other drugs is the social permissiveness that is there. And I think information technology is the way by which we can probably reach out to masses and change the opinion about these psychoactive substances. And there we have an information technology expert. Welcome, Rushabh. The question to you is, how does technology help in initial stages of pushing the thought of quitting? Do you believe that IT can help in making a public opinion against smoking? Do you believe that?
Yes, definitely. Technology, as we know it, once leveraged, can reach out to the very farthest corner and within no time. So definitely technology plays a major and great role in helping us in motivating also the people who are taking tobacco as well as people who are not taking tobacco to motivate others so that their near and dear ones can proceed towards tobacco cessation. So for this, we came up with the ICanCaRe application.
Can you tell us something more about your application?
So in the idea behind this application, developing this application was to empower each and every individual so that they have a readily accessible tool where they can assess themselves about their addiction level. They can assess their willpower. They can assess their signs and symptoms that they are facing, and also keep a record over a period of time. They can do their self-assessment on a monthly basis or a weekly basis, and they can record them. Whenever they find that there is a deterioration in their health over a period of time, they can quickly, through the application as well, seek assistance from a network of tobacco cessation specialists as well as multi-specialty doctors available on the application, where they can get the right treatment plan from these specialists. Also with this, as we have been talking about, that there has people who have tried to quit tobacco, they have this fear of failure again. So for this, again, we have put some motivational videos as well on the application, where they can see that, yes, it is possible to quit tobacco, and it is a journey that they can take. And with minimum, what we can say, परेशानी जो हम बोलते हैं, अगर हिंदी में बोले तो minimum परेशानी के साथ वो इस सफर को तय कर सकते हैं और आसानी से, with very ease, they can quit tobacco.
Yeah, thank you for helping physicians to help their patients. We need more of technologists in our field. Everybody has been quoting Mark Twain, so let me quote Oscar Wilde. He said that I can resist anything and everything except temptation. And craving is something which really triggers the relapse. Let me come to the dentist again, Dr. Garima. When you have so much pathology in the oral cavity, do the nicotine replacement therapies work or they don't? The other thing is that, I just said that, putting them from fire to the frying pan, we know that the tobacco has more cancerogenic system. So remove tobacco, add just nicotine, and it's a safer drug to take to control the craving. So your views on nicotine replacement therapy, your experience, and in cases of pathology, do you think that the absorption is hampered?
Yeah, I think nicotine replacement therapy, it definitely works well, especially because it reduces the craving. It's convenient to use. It does not stain teeth, which I like as a dentist. And it's also very cost effective. There are a lot of options like gums, lozenges, sprays, patches. We can also use a combination therapy in the nicotine replacement therapy. In terms of gums, I've seen that we need to be a little bit cautious when we use in patients with temporomandibular joint disorders. Also, I've seen that lozenges have worked better than gums because the absorption is more of nicotine as compared to the gums. And also some of my patients have said that the taste is better as compared to the gum. And it's well taken. They can also use patches. We have 24-hour patches in Australia that works quite well. Some patients I've seen that they use a combination of them, like they'll have a lozenge as well as they will use a patch. We also have the oral sprays, but the other thing to consider is that sometimes it can cause a irritation if you are using a spray, and especially if there, as you said, if there is already a pathology, a mucosal lesion that can cause more of an irritation with the spray. But I think it's a wonderful tool in smoking cessation because it's got its own benefits, and I think the patients can use it in their own pace. And if they don't like one of the options, then they also do have the other ones.
Yeah. Dr. Chawla, any experience with nicotine patches, nicotine nasal sprays? Have you used them in your practice, Dr. Chawla? Sir, can you hear us? Okay, Dr. Patel, you can take that question.
Yeah, at our regional cancer center, we use it a lot. But, as Madam said, the cost in India is little constrained. Secondly, consistency, to get the patch is not that easy for the peripheral centers. At regional cancer center, we can easily get all those patches and replacement. But, 80% of the India is in remote, in urban, rural area. So there it becomes a problem. And secondly, commitment of the patient is very poor. Say once the patient comes to us, I don't think I've seen any patient trying at the 8th time, So most of them, they either suffer cancer and they just quit like that without any support, because of social pressure. But those who are an active life without any disease because of the tobacco, I think in Ahmedabad, there are 2 rehab centers where, they charge particular amount of money and keep the patient indoor for a month for de-addiction. Now that is, completely non-productive. So I think gradually with the time, I think the attempts like this would improve overall package of the de-addiction program. And probably we might run such programs like Western world. And that is the time we are expecting very fast, We have to do that. Yeah.
Right. Yes, Dr. Deepak, any anti-craving substances that you use, your experience with bupropion and varenicline?
So quickly drawing a parallel, I do think the NRT works very well. I do not think it is substituting, just merely substituting one nicotine to another. It is actually doing away with a lot of combustible carcinogens that come with the combustion smoke of the cigarette that is inhaled. And of course, the idea is to start the patient on supportive work, preparing them for abstinence, so that it is a mechanism where the nicotine is only used as a replacement to be weaned off. Now, coming to bupropion and varenicline, so, one of the key chromosome that has been studied vis-a-vis the addictive process and the process of quitting is the chromosome 15. And various arms and various sites of chromosome 15 have been studied. And there have been actually some interesting studies to show which are the kind of samples who respond more to bupropion and which are the samples who respond more to varenicline. But both are good options in terms of deciding a quit date, but I still do feel, a lot of patients with whom I've used varenicline have come back to say they feel it's like a magical drug, I also feel apart from what the drug really does, there is a significant psychological support, the placebo component that comes with the whole process of recovery. The patient knows that there is help available. He's talking to a clinician. There is, whether he's talking to an internal medicine guy or a pulmonologist or a psychiatrist or a counselor, we're all doing counseling in our own capacity, and that's a huge support to the patient. So I think the moment patient knows he's into a program, he's being spoken to sensitively with empathy. And then I think if we've spoken a lot about the multimodal approach, it would necessitate that we do not discount the importance of some of these pharmacotherapies, which have been well studied and have tested across various double-blind controlled studies to show efficacy. So, I think these are both NRT, bupropion, vernicline, and other stress relieving, stress removing pharmacotherapies, along with psychosocial, non-pharmacological interventions woven into a program. They help bolster the confidence and the motivation of the patient to quit and to stay quit. The whole idea being that it's easy for them to get a quit date, to give up. And then, I think the repeated failures happen because the thought that one won't hurt, I can just do one. So you just have to start preparing the patient for that. It will never be that one puff. It will never be that one cigarette.
Right,
If you slip up, it'll be the process all over again. And I think with that support, we sometimes use a lot of relapse prevention strategies. We use a lot of cognitive behavior therapies. And I found that utilizing some of the principles of 12 steps, whether it's used for Alcoholic Anonymous or Narcotic Anonymous, but that one day at a time. I will not do it today. I'm having the craving right now. I will reconsider my craving after an hour. And we found that the cravings of tobacco, they're very intense, but they are very short lasting. So if you can do away with those few movements, the next thought is going to be different. They can go into a shower. They can go for a small jog, a run, a physical exercise, a massage, a hot water shower. And I think with these multimodal approach and mechanism, the results are pretty gratifying.
Right. Right. In de-addiction medicine, it's a rule that says that every dollar spent on prevention earns you more interest than every dollar spent on treatment. And that is the reason why any effort at treatment has to have accompanying effort at prevention. And as I said in the beginning of the program, when people make a choice of smoking, at that time, they should have sufficient information. And for that, a huge amount of social engineering is required. And again, for that, through social engineering, we look at the technocrats, Rishabh and your colleagues in the industry who would be able to understand the gravity of the situation, the kind of money losses that we have because of the tobacco use disorder. For the want of time, I would probably miss the question and come back to the last question. Dr. Patel, we want your wisdom, your understanding of the situation about what is the role of tobacco cessation clinics for general physicians, family physicians, any pathies that are there. What do you think is the role of tobacco cessation clinics? How will these people benefit if they have a tobacco cessation clinic under their roof?
I think, sir, this is a need of time, and I might suggest that that we should have a small course in undergrads of MBBS as well as in dental surgeries. And you rightly said all pathies, because the future is so close that there'll be a mix of pathies, and it is essential probably. So one, that my suggestion would be that we should have some sort 1 month or 2 month program undergraduates. We should start cessation center in all medical school, essentially by NMC. They should make an essential remark that all the hospital or all medical colleges must have a de-addiction center or cessation center, because a $1 spent for prevention probably would save $1,000 for treatment. Third important things, as a doctor, we work in isolation. I would request everybody of us that we should have collaborative lateral collaterals. Like, regionally, what I do is I would contact Chamber of Commerce, I would contact FICCI, I would contact partners of industry, I would contact school and colleges. I go there and talk about tobacco, alcohol, de-addiction, cessation. So I think, and once you add this feather in your cap as even family physician, this is a need of society. So by getting educated about de-addiction, probably you would not only serve the society, but commercially would make good amount of money also. So this looks a future direction towards cessation, and that requires commitment of all of us, as a medical fraternity. So I think you are the best judge, and you can conclude that God give us wisdom to take this task as our essential work.
Yeah, sir. It is said that don't poke your dirty nose into people's business, but here I think we have to poke our nose in other people's dirty businesses.
Yes,
So,
sir.
so with that, I would like to end this panel. Thank you very much for being very patient, and my apologies for the curtailed time. I would now request Dr. Sandeep Kadam and Dr. Harshad Thakur to give us their comments. Thank you so much.
Thank you, sir.
I think Dr. Harshad can take up.
Okay, thank you, sir. So I thank Dr. Pawan Gupta for inviting me in this ICanCaRe series of webinars. And I think this was quite a good, wonderful panel discussion. So we have presence of doctors from various fields, dentist, cardiologist, pulmonologist, oncosurgeons, and even IT specialist, and a psychiatrist, of course. So we had a very good discussion, and I think majority of the points are discussed. One or two points which I will like to add is, one is all of us are specialists. So we are dealing with patients when they are coming to us at specialist level. So we have to see that when patients in early stages, when they visit primary care physicians or initial phase healthcare workers, that time also they should be able to create awareness. Means we don't need to wait so long that after having cancer or major disease, they should be convinced about stopping the nicotine or tobacco. And second thing is technology. Yes, it is playing a role in reducing tobacco, but also simultaneously technology is a double-sided sword. So technology, we can see, is also promoting tobacco and tobacco-related products. So actually it is up to users how to use this technology. So technology like which Mr. Rishabh Agarwal ICanCaRe is using, they should see that this technology is more prominent and dominant as compared to other technology which is promoting these addictive products. So thanks again, and for final comments I invite Dr. Kadam sir.
Thank you, sir. Friends, it was a learning seminar for all of us. Even we have learned so many things during last 2.5 hours. First of all, I would like to compliment and congratulate Dr. Pawan Gupta and Dr. Desai for organizing this series of webinars for all of us. My compliments and my best wishes for them for future their endeavors. Friends, I am being a pediatrician, and also I am representing Rotary International District 3142, and I am very happy to inform all of you that during last year, last 365 days, we were working very hard, and we have undertaken pilot launching of program related to de-addiction. And I'm very happy to inform you that Dr. Ashish Deshpande was our scientific advisor, who was involved in last 2 years in planning this program as a ideator, as an advisor, and even we have interacted with so many of you. Dr. Harshad Thakur and many other faculty members were also a faculty for those programs. In that de-addiction program, we felt that creating awareness in the community and sensitizing the community is the basic start. As someone has rightly said, prevention is better than cure. Why can't we target school children, college going students adolescents, because they are the more vulnerable for this group. If they are aware what are the side effects of these kind of addiction, I am sure during their young age or reproductive age, they will be staying away from these addictive substances. As we all know that this is not a one-man job. It requires a multi-pronged approach. And I was very happy to see that you have involved almost all types of multi-specialities while dealing with the subject. I also would like to suggest that, and I also would like to compliment for also involving so many organizations who have joined hands with you, like even Rotary Action Group, Addiction Prevention of India, as well as international body. If we can really join with these NGOs, they have volunteers. Like we have in India almost 1.5 lakhs Rotarian who have committed, who have pledged to be a noble volunteer to serve the society. And they will be helping all of us in taking this project forward. So if multiple organization comes together, then I think we can really take this project for a long period. Another suggestion which I felt that we were attending about 160 participants. How many of us are smoking? That is a question. Or how many of us are using the tobacco products in whichever format? If at all few of us are using, we should be the first one to initiate the tobacco cessation, and then only we can lead from the front. That was another suggestion. Whenever we are attending OPDs, there we can have a video session for creating awareness and sensitization for the masses, where we can put those deadly pictures of having cancerous lesions and operated patients, so that they can really get a threat of it. The patients who are addicted, if they can really see what are the side effects, what are the endpoints of these addiction, they will be taking those steps to withdraw from it. And I think entire speakers who spoke from their heart, and they were passionate about doing works under this avenue. The Tobacco Cessation Clinic is also another good idea which has come up, and adding curriculum in the MBBS degree is also important suggestion which sir has suggested. I think if you all join hands together to see that the growing menace of tobacco use in India and all over the world can really be reduced with the efforts of each one of us. Thank you very much, and I thank organizers for inviting me to this seminar. Thank you.
Thank you so much, sir. It was really wonderful, and thanks to all the chairperson for the panel, moderator, Dr. Ashish, and all the panelists for the wonderful presentation that we had, and a lot of discussion and a lot of things that have come up. Of course, the next on the 25th, we are going to have a wonderful session where we will sum up and come up with some consensus how we can actually, like what Dr. Sandeep Kadam has said, how we can actually involve everyone and take it forward.